Okay, good morning, everybody. So this morning, morning here in California anyway, I'll be talking about COVID-19 and the heart. And just by way of putting this in some context in terms of how rapidly this field is evolving, the first publication on PubMed, if you simply search on COVID and heart, appeared on February 18th. And as of yesterday, we were up around 49, and this morning it's 59, and so there's 10 papers on this that I haven't read. And this is only on PubMed. If you look on medRxiv and bioRxiv, there's many, many more preprints that have been deposited there. As of yesterday, if you just search on COVID alone, there were 1,712 citations. This is all since late January when the term was first coined by the World Health Organization. So this brings up one important disclaimer. As comprehensive as I've attempted to be, this is a bit of a time capsule in terms of knowledge as of yesterday. Secondly, almost all the world's scholarly literature on this topic originates from China because they obviously got a head start on the epidemic. Because of that, some of the generalizations, especially the epidemiological ones, may or may not apply to other countries with different demographics and ethnicities. Having said that, I'll proceed to share with you sort of the state of the art of knowledge on this disease and how it affects the cardiovascular system. Another disclaimer at this point is that almost all the literature so far is clinical. There's very little by way of basic science right now on COVID-19, at least as it has to do with the heart. Many, many, many questions that have emerged, and I'm sure this field will be revolutionized in terms of the scholarly knowledge of what's going on. But right now, as I said, this is what we have. So in thinking about COVID, of course, the first step in the disease is infection, and the infection presumably happens by attachment of the coronavirus to ACE2 receptors in the lung epithelium, and after that there's a massive replication of the virus and a stage 1, which is characterized by response to the virus in a relatively stereotypical fashion relative to other viral illnesses, with some exceptions that I'll note in going along. Then within a few days, in patients who go on to be critically ill, there's a pulmonary phase where the clinical picture is dominated by dyspnea, hypoxia, and clinical features that are really dominated by the acute respiratory distress syndrome. And often these patients end up being intubated and always end up requiring supplemental oxygen when they're critically ill. The third stage, interestingly, becomes more of a systemic hyperinflammation picture in which the host response dominates the entire scenario. And here, our emerging concept is that there's friendly fire of the immune system, which also hits a lot of vital organs, including the heart, perhaps the kidneys, and certainly even secondary effects on the lung. Now, if you look at the signature laboratory abnormalities, something that is very apparent early on, indeed, we see it on admission to the hospital, initial presentation already, is lymphocytopenia. There's not an absolute decrease in the overall white count. It tends to be normal or slightly depressed, but if you specifically do a differential and look at lymphocytes, they're depleted relatively. And the depletion of lymphocytes, as I'll show you, is prognostically important and also tells us something about the possibility of recovery as well as the time course of the illness. During the pulmonary phase, you see highly abnormal chest CT and chest X-rays indicative of acute respiratory distress syndrome with a characteristic kind of ground glass appearance that's described in radiographs. And then in stage 3, there's elevated and inflammatory cardiac biomarkers, but there's substantial overlap among these various phases, and some patients can present with absolutely all of these, and others can present only with the lymphocytopenia. So rather than repeat the kinds of graphs that you can typically find on news channels and so on, just showing you where the disease is, I thought I'd reflect on some very interesting genetic epidemiology that's been done. It was published recently in this citation. And on the left-hand panel here, you see something that I think explains why this has become a pandemic. On the x-axis is the basic reproduction number, R0, and this is simply the number of patients on average that are infected by a given index patient. So if it were less than 1, as it often is in the seasonal flu, the illness would not propagate. It would be self-extinguishing. Anything greater than 1, by definition, means it's spreading. And for COVID-19, that number, as best we know it right now, is between 2 and 2.5. That's one thing to bear in mind. And then on the y-axis is the case fatality rate. And if you look all the way up here at Ebola, in which half of the infected patients die, that would be a self-extinguishing disease as well, because you could isolate those patients with simple public health measures. They die, and in so doing, they don't propagate the disease beyond a very local kind of population. So COVID-19 sits somewhere between the pandemic of 1918 for influenza and SARS, which was luckily contained in the 2002-2003 epidemic. But because it's got a relatively high R0 and a relatively low case fatality rate, it's kind of a perfect recipe for a pandemic. Many of these patients, we now realize, are fairly asymptomatic. If you look in the middle panel at the symptomatic case fatality risk versus age, and what this means is if you have symptoms, how likely are you to die? We see that there's really a monotonic increase beginning in the 5th decade of life and the 6th decade of life, and then rising continuously, such that the patients who are above age 79 have a very significant increase in symptomatic case fatality. But lurking beneath the surface is, I think, a very interesting finding, and that is that among those people who are infected, how many are actually symptomatic? And this is all normalized to a value in the 30s. So below the 30s, there's an increase, which is palpable already in the group between 20 and 29. And this increases monotonically well before the symptomatic case fatality rate does. And this is telling us something probably about the adaptive immunity response to the virus and how it manifests as a function of age, as does the symptomatic case fatality rate, but this actually seems to exhibit some kind of threshold phenomenon. The overall probability of dying after developing symptoms of COVID-19 inferred from these data is about 1.4%, which is much lower than the crude confirmed case fatality risk, probably simply reflecting the fact that the testing is so incomplete. So what am I going to tell you today? Some simple bullets. First of all, the immune overreaction kills people. Secondly, ACE2 binds the SARS-CoV-2 virus, but its role in COVID-19 is so far otherwise vague. Cardiac involvement is prominent. In therapeutics, there's a lot of pseudoscience, hype, and wishful thinking, and much more of that than evidence-based medicine. And finally, there may be long-term sequelae of infection. First of all, let's consider the relationship of lymphocytopenia and T-cell depletion to disease progression. If you look at these data published in JAMA and in Lancet, respectively, you can find that the time course of the white blood cell count, overall white blood cell count, in survivors tends to be fairly flat, and in fact is either normal or somewhat depressed. But in patients who go on to die, that becomes a relative granulocytosis, as you can see here on the right-hand panel. This is an increase in neutrophils. On the other hand, if you look at the lymphocyte count, you can see that survivors show some lymphocytopenia to begin with. It's very common to see lymphocytopenia as a presenting laboratory abnormality of COVID-19, and if you don't have quick access to the test, simply doing a CBC and differential can give you a clue. Survivors tend to hover around normal or just below, whereas non-survivors not only show an early depletion, but go on not to recover their lymphocyte counts. And this is also seen in the separate cohort here, where survivors have a progressive increase in their lymphocyte counts, whereas non-survivors don't recover and in fact show a progressive depression. If you go back to the SARS epidemic of 2002 and 2003, where there's a little bit of science that emerged after that, and the kind of science that we haven't really had time to do yet with the COVID epidemic, you find that by looking at electron micrographs of infected cells, that many white blood cells contain coronavirus-like inclusion bodies, which are seen here. But if you look at which ones do so the most, granulocytes are only 3% positive. Monocytes, which are macrophage precursors, are almost 30% positive, but over half of the lymphocytes show these inclusion bodies. So there must be at least a hint here that the most vulnerable cells to SARS-CoV infection, and presumably to SARS-CoV infection, the genomes are almost identical, are the T cells. And if you look at the clinical course during the illness, and this was again in the SARS epidemic, total T cells tend to be depressed in patients with SARS, and specifically seems to be a decrease in helper T cells, which are very important for modulating the later immune response, whereas cytotoxic T cells are somewhat less depressed. What about systemic inflammation and cytokine storm? Well, here's one of the cytokines that we associate with cytokine storm, interleukin 6. And if you look differentially at and this is retrospective data, but it seems to hold up as we look now prospectively in our series and others. The survivors have a flat interleukin 6 curve, whereas in non-survivors, interleukin 6 is elevated and progressively gets more elevated over the time course of this fatal illness. Likewise, another somewhat less specific biomarker of systemic inflammation, serum ferritin, seems to dichotomize between survivors and non-survivors. And if you look here at the patterns for C-reactive protein, perhaps the least specific of all the markers of systemic inflammation, or the most general, there's a highly significant difference in the course of the illness between those who go on to die and those who go on to be discharged with a very high CRP, and those who in whom the case was fatal. And likewise, reproducing in this other series, the data seen here for interleukin 6 as an apparent prognostic indicator of mortality. There's no, when we look at, so let's jump now to the whole ACE2 basis of infection in SARS-CoV and its role in cardiovascular morbidity. There's certainly a theoretical basis here for susceptibility differences among populations, maybe even in age, but it's not really even clear whether high ACE2 to begin with is a good thing or a bad thing. It may be that it's relatively protective because the virus itself depletes ACE2, and it may also determine the pattern of infection given relative expression patterns in different tissues. But there's really no data demonstrating benefits or detriments of renin, angiotensin, aldosterone system antagonists just yet, other than some preprints that have appeared in the Chinese literature on the archives. But we do know for a fact that SARS-CoV-2, like its precursor SARS-CoV, can infect host cells via the ACE2 receptor. And now even at atomic resolution, we know how the SARS CoV spike domains interact with human ACE2. And how might this affect ventricular function? Well, this is all conjectural, but we do know from previous work on ACE2 knockout mice, no infection here, just knockout of the ACE2 gene, they develop poor left ventricular function. And we also know that SARS-CoV, at least, and I think recently also in the archives, SARS-CoV-2 lower the expression of ACE2. So if you put 2 and 2 together, these findings are compatible with the notion that SARS-CoV inhibits ACE2 and thereby depresses LV function. But there's no corollary data yet in humans, and only some preliminary data that have been published with SARS-CoV-2. So what's the controversy of renin-angiotensin-aldosterone system antagonists in COVID? It doesn't take much creativity to imagine that if you use a small molecule that interferes with the function of ACE, that these might modulate somehow the propensity to infection. And certainly in animal models, ACE inhibitors and ARBs, angiotensin receptor blockers, have been shown to increase the expression of ACE2. So this leads to the speculated and completely theoretical risk of increased SARS-CoV-2 infection. But as I've mentioned, ACE2 expression may actually be a good thing. So this could cut both ways. And it's possible, indeed, that the directionality of these presumed prejudices might be wrong. Certainly the role of ACE inhibitors and ARBs in COVID-19 patients is uncertain, and all the major societies to date recommend just continuing the present therapy in patients who are well controlled for their hypertension and or heart failure with such drugs. Cardiac involvement is prominent. We wouldn't be having this seminar if it weren't. It's a major cause of death. The elevations of troponin I and BNP are common and associated with poor outcome. But the extent of genuine myocarditis so far is unclear and probably somewhat exaggerated. If we look at the causes of death overall in patients with confirmed COVID-19, a full 40%, this is again from the Chinese epidemic, are attributed to either exclusively to myocardial damage or heart failure, which actually accounts in this series for a full 33% of deaths, with another 7% being cardiorespiratory, for a total of 40% implication of the heart in mortality. And we do know for sure that biomarkers of cardiac injury are associated with increased mortality. Witness here the association of cardiac troponin I in patients who died versus those who were discharged. Likewise, the time course of TNI is ever increasing in patients who do not survive as opposed to survivors. Likewise, we know that those patients who have some evidence of cardiac injury have a poor survival relative to those without evidence of cardiac injury. One caveat with these findings is that this may simply be an association rather than a causal link, and this may simply reflect the overwhelming systemic inflammation and a troponin leak on that basis, as opposed to genuine primary cardiac illness. So the mechanisms of cardiac injury do now include, for sure, the secondary effect that I was just talking about, where hyperinflammation has effects on the heart that include elevated biomarkers and perhaps clinical manifestations of arrhythmias, increased propensity to acute coronary syndromes, conjectural and not yet demonstrated, and both heart failure preserved ejection fraction and low-level myocarditis, or heart failure with reduced ejection fraction and fulminant myocarditis. The mechanisms also involve direct myocardial injury. At least this has been shown in the propensity of SARS-CoV-2 to actually directly infect cardiac myocytes has been argued to be the case and has been shown in some cases. And this, in some cases of verified myocarditis. Certainly respiratory failure and hypoxemia can indirectly depress cardiac function, as the membership of the society will well appreciate. So how prevalent is myocardial injury? Well, if you look at one case series here, at least sometime during the illness, troponin and T values were elevated over normal. And in another series, those looking at collective biomarkers, including troponin I and troponin T, about 20% of patients here were argued to have some cardiac injury during the course of the illness. But the number of autopsy specimens is very, very small. And certainly the number of patients that have inflammatory infiltrates with cardiomyocyte necrosis, where it's documented, is very, very small. The number of case reports for fulminant myocarditis can be counted on the digits of one hand. So subclinical myocarditis may be common. The true incidence is so far unknown, but fulminant myocarditis is possible, but at least so far quite rare. What about hypertension and hypotension? When we first learned of the SARS-CoV-2 epidemic, one of the first major papers on this argued that a presenting sign of patients who went on to need intensive care in the Chinese cohort and from Wuhan, they were actually hypertensive, which is as those of you who have ever been sick, or those of you who have ever taken care of critically ill patients, is quite bizarre. Critically ill patients tend to come in hypotensive, not hypertensive. And so this made us wonder collectively whether SARS-CoV-2 might cause hypertension, or whether perhaps hypertensive patients are at greater risk for increased viral load. But it turns out that at least in the US literature, it's much more common to present with low blood pressure and a requirement for vasopressors. And indeed, in our series here at Cedars-Sinai, which collectively now involves several hundred patients, there's no increase in blood pressure in patients who are critically ill, and in fact, a general decrease. What about the risk of acute myocardial infarction and acute coronary syndromes? Well, there's certainly good reason to expect that it might happen. There seems to be a hyperthrombotic kind of phenotype in SARS-CoV-2 infected patients, consistent with the fact that there's a systemic hyperinflammatory response. But if you look at D-dimer levels, which basically are products of a clotting reaction, and measure them in the blood, you can see that they're quite normal in patients who survive, but very elevated in non-survivors, and progressively so with an increase in the illness. Which brings about a long-standing literature of many decades of the interface between inflammation and thrombosis. Among the contributing and predisposing factors to thrombosis from inflammation include endothelial and smooth muscle cell activation. Macrophages, of course, are known to be activated, and tissue factor expression increased in atheromatous plaques. And platelets are activated with additional production of pro-inflammatory mediators. All of these would tend to be pro-thrombotic contributors. And certainly in prior epidemics of respiratory infections with influenza B or influenza A, RSV, and other viruses, there seems to be a higher incidence of acute myocardial infarction within 7 days of infection, with the ranges of risk ranging from about 2.7 to 10. But the true incidence of acute coronary syndrome and acute myocardial infarction in the COVID epidemic is currently unknown. What we've heard from our colleagues, not only in China, but also in Italy and Spain, and so far here in the United States, is that there is not a big rush for cardiology consults related to acute cardiac ischemia. Arrhythmias seem to be found, although they're very poorly characterized, and they can be tachycardias, bradycardias, or even sudden cardiac death and asystole. Here is one very relatively rudimentary characterization: heart palpitations, not really very helpful. Many patients present with a tachycardia, perhaps just reflecting the severity of illness. This was the admission electrocardiogram of a 31-year-old in Wuhan who presented with multi-system failure, got intensively treated, and ended up being discharged to home. In another series, arrhythmias tend to be more common or more prevalent in patients who were admitted to the ICU as opposed to those who were not. But these arrhythmias were uncharacterized. Therapeutics has gotten a lot of attention in the lay press, and I think it's fair to say that there's much more in the way of wishful thinking and hype than there is evidence-based medicine, although slowly some controlled trials are emerging that hopefully will serve as guideposts as we have more experience with the pandemic. I'm not going to say anything about anti-IL-6 or anti-IL-6 receptor antibodies other than the fact that they're being used off-label in COVID-19 patients with anecdotally some great success. But let me turn our attention to the antimalarials, chloroquine and hydroxychloroquine, with and without the antibacterial agent azithromycin, as well as some other drugs that are in development. Remdesivir, a nucleoside analog initially developed for Ebola, where it wasn't particularly effective, but now being tested in patients with COVID, antivirals, and corticosteroids. The whole kind of fascination with the antimalarials began actually well before the COVID epidemic, where in vitro tests had shown some efficacy against a number of other viral illnesses, including influenza, but clinical trials tended to show absolutely no benefit. Nevertheless, early on in the course of the epidemic, hydroxychloroquine was tested in vitro on SARS-CoV-2, where it was argued to inhibit infection in vitro. Then on March 3rd, a randomized clinical trial showed no differences in viral loads or clinical recovery between hydroxychloroquine and control groups. But the plot thickened with a much hyped, very controversial article showing decreased viral loads and rapid viral clearance in a subset of patients treated with both hydroxychloroquine and azithromycin in a very poorly controlled small study from Marseille, which was then compounded by a larger study with no comparison group from the same group, showing an apparent improvement of length of stay and contagiousness relative to basically a historical index. Incredibly controversial. But the plot thickened even more just a couple of days ago when a preprint appeared with a 62-patient series out of Wuhan, randomized 1-to-1 between hydroxychloroquine and conventional care. And the conclusion was that there was a shorter time to clinical recovery in the hydroxychloroquine group. Again, collectively a very small world literature upon which many tens of thousands of patients are being treated off-label with these drugs that incidentally are known to increase the QT interval and cause a sudden cardiac death. If you look at lopinavir and ritonavir, which is a cocktail that was developed for possible use in AIDS and showed in vitro activity against SARS-CoV-2, this was the first placebo-controlled trial to appear in the literature and showed absolutely no benefit either in terms of clinical improvement or in terms of viral load. So there's a lesson in this trial, which is probably the best one so far in the COVID literature. And the message is early enthusiasm needs to be tempered by long-term reality. What about corticosteroids? Certainly data from prior viral epidemics don't support corticosteroid use. In all of these previous epidemics listed here, the outcomes were either neutral or deleterious, and many side effects occurred. Having said that, in SARS-CoV-2 infected patients, corticosteroids are used not infrequently in critically ill patients. But what we do know is that there's no apparent mortality benefit, and the corticosteroids only worsen the lymphocytopenia. So we can't recommend them for routine use. I'm going to tell you a little bit about emerging trials of cell therapy. And this is motivated by a general thought that if you have cells that may be anti-inflammatory, immunomodulatory, and may act on T lymphocytes, that perhaps in a way never intended from the initial use in regenerative medicine, such mechanisms may be helpful. And we've started such a trial at Cedars-Sinai, which uses the kind of cells we've been interested in for some time, cardiosphere-derived cells. But it's important to say that there's a very small literature that's already been deposited on preprints using mesenchymal stem cells in China, and I'm aware of at least 4 other trials that are incipient in the Western world that use other cell types. But this is the rationale for our study, which I'll tell you about later. The recipe for making CDCs is well known and is published and has been reproduced in over 200 laboratories or in over 200 publications from more than 55 independent laboratories worldwide. We now appreciate the mechanisms of action to include cardiomyocyte survival being enhanced, anti-inflammatory immunomodulatory effects, mediated by secreted extracellular vesicles. And in clinical trials of CDCs, which now have involved over 200 patients worldwide, there seems to be signs of bioactivity, disease-modifying bioactivity, although not always the disease-modifying bioactivity that was anticipated at the beginning of the trial. For example, in the All-Star trial, which was pre-designed to show a decrease in scar size by magnetic resonance imaging. There was overall placebo-controlled and double-blinded. There was overall no decrease in scar size, but there was a significant, at the 0.01 level, decrease in end systolic volume and end diastolic volume and in serum biomarkers of heart failure, specifically NT-proBNP. So why even think of using this in COVID? Well, if you think of SARS-CoV-2, we don't have any reason to believe that the CDCs or their exosomes would alter epithelial entry and destruction and direct infection of leukocytes. We're testing that idea right now, actually, in collaboration with a BSL-3 lab locally. But what we do know is that once the inflammatory cycle gets going, regulatory T cells are involved, as are effector T cells, macrophages, where the macrophage function and enhanced efferocytosis might play an important cleanup role, especially in intense inflammatory deposits like those in the lung. Systemic cytokines are elevated, leading to systemic inflammation and multi-organ dysfunction. And at every one of these choke points, there is evidence for effects of CDCs on pro-inflammatory targets, consistent with effects that have been quite uniformly positive in a number of preclinical models, ranging from myocardial ischemia and myocarditis to muscular dystrophy, different types of heart failure, senescence, and pulmonary hypertension. And so far, clinically, the company, Caprigor, for which I had a disclosure in my slide as being a founder, has gone all the way through phase 2, with the clinical program for Duchenne muscular dystrophy being the most advanced, and some recent very promising data from their ongoing placebo-controlled clinical trial of boys and young men with DMD. But to show you just some tantalizing new evidence as to why these agents, CDCs and their exosomes, might be particularly helpful in COVID, we now know from data that was published recently from Lillian Gregorian when she was in my lab. She's now in the front lines of taking care of COVIDly ill patients in Madrid. But she found in accelerated aging models in rats with heart failure preserved ejection fraction these animals get an increase in IL-6, for example, which is attenuated by CDC treatment. In unpublished data from Shah Akmirov in my lab, the T cell proliferation as well as T cell activation is increased by exposure to CDCs in a transwell culture or to their exosomes directly. And not only do CDCs increase the proliferation of regulatory T cells, but they also increase IL-10 production by regulatory T cells, but don't activate pro-inflammatory effector T cells. Again, in unpublished work by Shah in my lab, CDC exosomes are effective, apparently, in a model of autoimmune myocarditis, echoing prior work from Kostas Meliaris's lab in Greece, in which he published effectiveness of CDCs themselves in a very similar model of experimental automyocarditis in rodents. You can see that there's not only benefits on ventricular function, but also apparently on QT intervals and a decrease in inflammatory severity based on histopathology. So this all leads to the CS-CUBE trial, CS-CUBE being an acronym for CDCs, for cytokine storm and COVID syndrome. And the inclusion criteria for this trial, which is an open label observational study at this point, confirmed COVID-19 and critically ill patients, and they all have to have lymphocytopenia plus at least one from the menu of elevated IL-6, tropin, and myoglobin, or CRP. The intervention here is intravenous allogeneic CDCs, what the company has called CAP1002. We know from prior preclinical studies that the intravenous formulation works well, at least in Duchenne muscular dystrophy models. And there's evidence from the ongoing HOPE-2 trial, interim analysis thereof, that IV CDCs are efficacious in several parameters of not only cardiac, but also skeletal muscle, in halting progression of skeletal muscle weakness in that setting, and also in improving cardiac function. And we're going to give these, or we are giving these weekly, up to 4 doses. So far, we've recruited 2 patients, one of whom has been treated once, and the other of whom has already gotten 2 doses. Both of those patients are doing quite well and were critically ill when given the doses. The outcomes are all exploratory so far. We're going to be looking at mortality, length of stay in the intensive care unit, the need for escalation of support, and a lot of biomarkers in collaboration with Jenny Van Eyck, as well as for discovery purposes, as well as conventional biomarkers. Even though I've told you we've recruited 2 patients and they're doing well, another sort of editorial comment that I'll make at this point is that we found here a much lower mortality for critically ill patients overall than is described in the literature. I think if you can give these patients outstanding medical intensive care, they often recover, even very elderly patients do. So that in our experience of treating over 50 such patients here at Cedars-Sinai, we've had only 3 deaths, and one of them was a 102-year-old patient. So that's a cautionary note to say that even though our patients treated with CDCs so far has shown improvement, that a placebo-controlled trial is eventually going to be necessary to be sure that there's actually net benefit from this intervention, although there's good reason to believe that it might work. So what about long-term sequelae of the disease? Here the literature is very sparse and is largely dependent on what little work there was on SARS-CoV virus survivors, SARS-CoV virus survivors from the SARS epidemic of 2002-2003. The total numbers in that epidemic were relatively small, just in the thousands. And so the number of survival studies is quite limited, but so far what there seems to be is some realization that there is, and this is a conjectural slide, but it's consistent with everything we know about the SARS SARS epidemic and what we know so far about the COVID epidemic, is that there's an acute phase, which was summarized in the first slide that I showed, and the first schematic slide of progression of the disease. But once that's over, the patients who go on to recover, of course, decrease their disease severity over time. They go into a convalescent phase that isn't rigorously defined, but we sort of think of it from, let's say, day 21 or so in the illness, when patients begin to be ready for discharge once their virus is cleared, through several months perhaps. And during this convalescent phase, what we found is that there are cases of delayed myocarditis, and even patients whom we think are ready to go home who suffer asystole while walking the halls. So just a cautionary note that we may not be out of the woods even after the virus has apparently been cleared. And then from the SARS literature, there are reports of persistent hyperlipidemia and pulmonary fibrosis and hypertension as sequelae of SARS-CoV infection. So much remains to be learned here, and the question marks are purposefully put in to indicate that our knowledge base is quite limited. So just to summarize, immune overreaction kills people. I've told you a little bit about ACE2 and its critical role in infection, but otherwise unclear role in cardiovascular disease progression. I've mentioned that cardiac involvement is prominent, talked about emerging therapeutics as well as the controversies therein, and at least sensitized you to the possibility of long-term sequelae. I want to acknowledge Shah Akhmarov for helping put together this presentation and for his unpublished work that I showed. Ahmed Ibrahim, Jeff DeCuto, and Russell Rogers are the other 3 members of the COVID task force within my laboratory, and Raj Makar, who is the principal investigator of the CS Cube trial. And even though we have no specific funding for COVID, this is the history of recent funding in my laboratory listed here. Just finally, this is where I'm broadcasting from, literally from this point in this building. This is a rare day in Los Angeles where there were actually clouds in the sky. This building, which is the Advanced Health Sciences Pavilion, is shown here in the aerial map. Some of our laboratories are on the top floor of this building, including Jenny Van Eyck's and Robbie Gottlieb's. My own laboratories are in this other research building here, and this U-shaped structure is the main clinical hospital, with the ICUs being in the Saperstein Tower, and some of the cath labs and ORs being distributed over in this building as well. Thank you very much. Help me get to
so thank you very much, Eduardo. I will just enable a gallery view again. And, oh, I think that's enabled already. So
these are the Q&As.
Oh, okay.
So I'm hoping that everybody can see all the people on the panel.
All right. So
so if you want to answer questions, there is a Q&A box. Hopefully you can see it at the bottom of your screen. If you click on it,
okay,
you will be able to see all the questions. You can scroll down. There's 21 questions. I should also say that we were running on average about 760 attendees, plus a substantial panel. So I guess we're at around 770, 780 people that actually tuned in today. So quite impressive.
Okay, so I'll summarize the questions as I see them and give a verbal answer. The first question by Mauro Costa is, what are the possible correlations between RAAS system changes mediated by ACE2 modulation by the virus? And there I have to say I don't know anything other than what I said, which is very little. Lucie Carrier asks an interesting question. She notes that the ACE2 gene is located on chromosome X, and are there any data showing a difference between men and women? So it's been speculated that men are more susceptible to SARS-CoV-2 infection and the COVID syndrome because they have a relative hemiallelic insufficiency and lower levels of ACE2, we males having only one copy of the gene, and females having two, given the dual X chromosome. But so far, the correlation between genotype and phenotype is not very clear. And certainly, if high ACE2 levels are protective, that argument is at least from first principles consistent with some predilection to worse disease in men. Sobia Fanti asks, how is myocarditis diagnosed in patients with COVID? This is a non-trivial question because a lot of what is inferred as myocarditis is simply due to biomarker elevations. It's incredibly difficult, just technically, to get high-quality echocardiograms in these patients to see if there's a ventricular dysfunction, both because of staff exposure to a critically ill patient, as well as from the personal protective equipment, making it quite difficult to get all the intubation of the patient and the patient's relative immobility, making it quite difficult to get rigorous views of the heart. So you can imagine the echocardiography literature on COVID patients is really almost non-existent. In a few flagrant cases where the patient clinically is in heart failure, burbling with hemoptysis and every indication not only of by radiography, not only of ARDS, but also superimposed heart failure. Those are the ones who make it into the case report literature, but what I said is true, which is that the number of such confirmed cases is vanishingly small. And finally, endomyocardial biopsy, which is usually or often often done to verify the diagnosis histologically, has never been done, to my knowledge, in a patient with COVID-19. Manish Kala makes an observation that blood pressure observation may be related to the delayed presentation in the US cohort after a period of isolation. And it's noted that his experience in the UK is similar, whereas in China, admissions were earlier due to cohorting in specific facilities. This is more of a comment than a question, but I thought it was worth sharing. Michelle Russo asks if there's a correlation between Tregs and COVID-19 infection, and should their anti-inflammatory effect protect against the viral infection. So far, this is a consistency argument. We certainly know that Tregs, T cells in general, and probably Tregs were depressed in SARS. And there's no data yet that we know of specifically on Tregs in COVID-19, but certainly everything we know about them biologically would tend to make us think that increasing their number and their activity would be helpful in countering the cytokine storm and the secondary systemic inflammation picture. Rio Juni asked, do COVID-19 patients with heart manifestations already have a history of cardiac problems? We have looked at that in our own series here at Cedars-Sinai, and there's something like a twofold increase in apparent criticality of patients, depending on a prior history of heart problems. But it's not clear how many of the patients who actually manifest overt heart disease have prior histories of cardiac problems. And certainly there's a number of cases in the literature, as well as anecdotally, of patients who present with something that resembles an acute coronary syndrome, echocardiographic abnormalities and chest pain, who go to the cardiac catheterization laboratory and have clean coronaries. Marina Anastasio asks, is there increased vascular endothelial permeability in infected patients? And is there any difference between groups with diverse severity manifestations? Good questions to which I don't know the answer.